Good morning to each and every one of you, our valued new and first year students that are joining in on this faculty orientation exercise this morning. I'm Jarrell Alder, Program Coordinator at the Division of Student Services and Development, and it is my absolute pleasure to be among the first to congratulate and welcome you to your first year experience right here at the UWI St. Augustine campus. So as new students, your orientation and transition is important to us as we recognize the direct connection it has to you achieving the highest levels of success in your first year of study. With this in mind, the First Year Experience program was developed specifically to meet your informational demands, acclimatize you to your new university environment, and help you in getting comfortable as you prepare for your exciting university journey with us. Today, you will be oriented into your dynamic faculty, the Faculty of Medical Sciences, and we ask that you pay close attention to the information that will be shared with you as you get ready to explore the life-changing university experience that awaits. Guiding you through today's orientation exercise is the dynamic team at the Faculty of Medical Sciences, and I hand you over now to guide you through the session, Dr. Sa, Deputy Dean in the Medical Sciences Faculty. Over to you, Dr. Sa.
Thank you very much, Mr. Gerald, and warm welcome to all our colleagues, those who are joining. And special warm welcome to our students coming to the Faculty of Medical Sciences. And now I would like to come on the screen Professor Chidam Ejenwaka, our Deputy Dean for Basic Health Sciences and Professor of Pathology, to come to the screen and welcome our students and present our acting dean and carry forward the early part of this orientation week program. Professor Ejenwaka, please, over to you.
Yeah, thank you, Dr. Sa. Yeah, good morning, members of staff and our new students. I wish to recognize the acting dean, Professor Michael Randall, is in the room. I have other many senior members of staff. We have Mrs. Reed, the head of library, is here. We have our associate dean for public relations, Ms. Ivy, is here. The head of optometry unit is here, and the director of dentistry is here, and Dr. Sa, of course, recognized. It is always my pleasure as the deputy dean, basic health sciences, to have the opportunity to welcome all the new students coming into Faculty of Medical Sciences. I am here in my capacity as the Deputy Dean for Basic Health Sciences, in which case many of the students, especially those doing medicine, will be interacting closely with me and my staff for the first 3 years. But on personal note, I am a professor of chemical pathology, and I will be teaching those in medicine, veterinary medicine, and dentistry in year 1 and in year 3. Having said that, there are things that I need all our students to understand. We pride ourselves as members of this university that is 3 scores and 10, 70-something years old university. And this university has been ranked by Times International as among the best 4%, and in the Caribbean, the first. So anybody who is here should consider yourself as privileged of becoming a member of this large family. I always take the pride to say that I am also an alumni of a university in Nigeria that was established at the same time with this university. And I'm always proud to say that I was trained by such, and I am teaching you all. Many of you have been longing to enter the Faculty of Medical Sciences, be it medicine, dentistry, veterinary medicine, pharmacy, optometry, or nursing. This is the only faculty in this university that have all 6 professional schools put in one. That makes it unique. And I'm always proud to tell the Vice Chancellor or even the principal that this is your favorite faculty, because this is the teamwork and the unity in progress of health professions. If you are here to read medicine, when you get to the ward, you have to meet the pharmacists, you have to meet the nurses. The optometrists are there. All the professional schools are in one place here. That is the reason you will be exposed to the lecture on One Health. one health program that bring all the healthcare profession into one roof of the faculty. And we are proud of that. And going through to become a professional that you want to be a nurse or optometrist or a pharmacist or a dentist or veterinarian. It has taken you a long time and really hard work to qualify to enter here. And I always like to tell students upfront that as it was very challenging for you to come in, it will not be less in going out because the work to go through this is also very challenging. But at the end of the day, you will be happy you did. So from day one, that's today, you take your admission into this school seriously and take everything that is being said from today till 11th, and next week we start lectures very seriously because I am the chairman of the curriculum committee for the Faculty of Medical Science. Our curriculum has not changed because of COVID. Whether we are teaching you online or we are physically doing that, our curriculum remains what it is. And whether we are going to examine you synchronously or asynchronously, our curriculum and our standard will not change because many of us are passionate what it takes for us to give you a license either to heal a human being, animal, or for you to dispense or for you to care as nurses do. So the business here is not the business of guess what? We don't guess at the Faculty of Medical Sciences. We are doing it evidence-based. And as such, our products are all over the place. The University of West Indies pride in itself as the university that have produced the leaders in the society and academia. Many of the people that will be teaching you are alumni of this university, and they cannot afford to dilute what we are here for. So I will encourage you, and perhaps the acting dean will say more on that. We take seriously our value system. And I know that many of you might be sitting in your bedroom or on the couch or as you are listening to me. That does not mean that you are not in school. I take it seriously that you are in school as I'm talking to you now. So you take it very seriously. Another social opportunity you will have in many universities, including the university where I was trained, I didn't have the opportunity of having all the health professionals in one faculty, but you are so privileged. If you are living in the same hostel, you will have opportunity to know if you are in medical school. You will have opportunity of seeing how tedious it is to read veterinary medicine. You will know what dental students are doing. And even as at that, in medical school here, they share the same courses with dental students and veterinary medicine. And we have interaction with pharmacists and other groups. So you will learn from the word go how to go about your business. And you will also have opportunity of interacting and making lifelong friendship. You will get your friends. Some people in this faculty have graduated and get their life partner from among the professionals. I have several examples having been long here. So this is a unique opportunity for you to interact. And those of you who are nationals, I always extend the workshop for you to remember that we have regional and international students. It is easy if you are 4-5 from one secondary school here for you to know yourselves and then join in the university. But there are others from Barbados, St. Lucia, Bahamas, or even international students. I know we have admitted many international students. I would like those who are nationals to be hospitable and reach out to those individuals to carry them along, even visually as we are looking, in such a way that you will all carry on the team spirit of this faculty and extend it to yourselves to tell yourselves what is happening, give others information about lectures and seminars, about assignments that are given. We encourage that in this university, and we encourage students and staff to remember that we market ourselves, public relations, to extend it beyond our shores. And for those who are reading medicine, the medicine you are reading in St. Augustine is the same. It's the same curriculum with your colleagues who are in Barbados in Cape Hill, and those who are in Mona in Jamaica, and those who are in Bahamas. At the end of the 5 years, you will take the same examination, and it's the same vice chancellor that will sign your certificate. So it is up to you to work hard in that direction. I welcome you, and I am very proud of you for choosing the University of the West Indies and our faculty as your first choice. And we are happy to welcome you to our faculty. And do not hesitate at any point in time to contact the office of the dean. There are a lineup of administrative assistants in the dean's office who are there to help you, from the administrative officer, who is Miss Roberts, that is perhaps listening here. You will go to the Faculty of Medical Sciences website. You see DNA. We have senior administrative assistant dedicated for solving the problems of students. If it is in basic health sciences, I have a clerical assistant and Ms. Ramatison is my to deal with any problem you have. In each of the schools, those in veterinary school, in dental school, in nursing, in pharmacy, you have administrative assistants in each department, and they will respond to you in no time in any query you have, regardless of the fact that we are doing all this visual. So do not give excuse. I bet you that people will respond to your questions in less than 30 minutes, and you will get it going. That is how we are operating at this point in time. And we have the library services. Library is very important, and I think there's a section of your orientation where you will be introduced to our library. And there's remote resources that are available that you will also, as I said, we wouldn't say because you're not here that you wouldn't use the library. The librarian, they have made necessary arrangement for you to remotely access the laboratory services in all aspects. But where you have problems, do not hesitate to contact us. I believe that at the end of the week, you would have been very familiar with the workings of our Faculty of Medical Sciences, our flagship faculty. We are very proud of that. I always said that. I'm proud of Faculty of Medical Sciences, and I hope you will be at the end of your course. Thank you very much. It is my pleasure, I think. It's my pleasure to introduce the acting dean, Professor Michael Randers. He's a professor in surgery. He's a surgeon, but principally he is here not as a surgeon, but as the acting dean. And he will address you on many other aspects on behalf of the dean, Professor Simongon, who is unavoidably absent today. So Professor Ramdas, you can take off from here. Thank you for.
Okay. Well, good morning, everyone. It's a rare pleasure to have this opportunity to speak to you all and give you all an introductory address. It's the first time I have done this from home, and it's a new experience for all of us here, as well as yourselves. So I just want to tell you welcome, and I'll start my talk now. So the Chancellor, the Pro-Vice Chancellor and Principal, fellow Deputy Deans, heads of departments, lecturers, administrative staff, specially invited guests, and most importantly, you, the students and parents of the current 2020 matriculated year. In the timeless words of Charles Dickens, I'll say, it was the best of times. It was the worst of times. It was the age of wisdom. It was the age of foolishness. It was the epoch of incredulity. It was the season of light. It was the season of darkness. It was the spring of hope. It was the winter of despair. We had everything before us. We had nothing before us. Students, friends, colleagues, I've been asked to bring you greetings today on behalf of the sitting Dean of the Faculty of Medical Sciences, Professor Terence Simongon, who could not be present due to urgent matters. This year has been all the things I just related to you above. There was light, there was darkness, there was hope, there was despair. We have everything, but yet we have nothing. I must tell you, it has been an accelerated learning experience for the University of the West Indies, regionally on all campuses, like many other universities worldwide and education systems globally, whereby curriculum committees accreditors have had to rapidly invent, conceptualize, deliberate, and determine solutions on how to explicitly deliver and examine a medically related syllabus online with no physical contact. It has affected us all as educators to not have our students in a physical setting environment, which is necessary and we have grown accustomed to. But nonetheless, I am pleased to relate to you that the seed of positive energy has been sown into the soul of this university to transform and adapt to the situation at hand in order to adequately and expertly deliver the curriculum whilst maintaining standards and accreditation with the relevant international bodies. I reassure you today, the degree which you are about to embark on is second to none, as emphasized by UWI's rise in global rankings. As the University of the West Indies evolves to become more efficient from being environment friendly, energy friendly, and a technological perspective, it has invested in all the necessary software, equipment, training, and successfully delivered online teaching in all subject areas, going from anatomy, physiology, pathology, clinical surgery, internal medicine, and allied sciences, including nursing, veterinary science, dentistry, pharmacy, and optometry, which are all part of this great faculty. All we expect from you, what we expect from you professionally, is simply explained in a saying that I believe in. It was said by the late Albert Einstein, and it is composed of 3 rules of work. Out of clutter, find simplicity. From discord, find harmony. And in the middle of difficulty lies opportunity. I urge you to grasp this opportunity at hand and allow the new world with all its power and might to step forth and allow the old to become naturally fossilized in time as the days of yore. And it is with this that I conclude. I wish you all the very best in your future endeavors in this faculty, and I hope that we can meet in person one day when circumstances permit, and I'll encourage our dean and faculty executive to hold something as soon as we could physically meet. And I just want to thank you for this opportunity, and may God bless you. Thanks, everyone.
Thank you, Prof. Ramdas. Next up, we have this morning on the program Dr. Lennox Pear. Dr. Lennox Pear is a specialist physician in internal medicine and neurology. He was the hospital medical director of the Sandy Grande Hospital from 1990 to 2006. He graduated with his medical degree in MBBS from the University of the West Indies in 1973. I now present to you Dr. Lennox Pear.
Yes, this is Dr. Pear here. Are you all hearing me?
Yes, we are.
Okay. Dr. Sa, Dean of the Center of Medical Sciences, Dr. Ramdas, Acting Dean of the Faculty of Medicine, members of faculty, first-year medical students. I am very, very happy to return to the university, even though in a virtual capacity. And professional practice. My student days at university were some of my happiest. And you must not miss the opportunity that this experience gives you to interact with your colleagues, forge friendships, and many of these friendships last a lifetime. Value important determinants of any human endeavor. Desirable values are what influence the quality of your life and they are applicable also to the field of medicine. I must commend the university for recognizing the need to fill the void of law and ethics to which my generation was never formally introduced and is reflected today in the highest levels. I myself had my own epiphany when, after a colleague of mine encouraged me to do law, and he fooled me and gave me the idea that it was, he says, man, you could do it part-time. Well, it wasn't really that easy, but it gave me an insight into the law at a late stage of development, which I did not have previously. Now, you all are students, and I'm telling you that all that I'm telling you may not be directly applicable immediately, and you may not appreciate it at this point in time, but they are important for you to internalize them, even as you look initially at the sidelines. Learning the work in medicine is about certification. Understanding the larger context in which you would function in the interest of patients is about education. And the university, I'm happy to see, is about education. Law and ethics need to be taught and assessed just like any other subject. The Hippocratic Oath was since 460 BC, and it spoke to moral conduct. It says, swear by Apollo the healer, I will prescribe regimens for the good of my patients, according to my ability and judgment, and never do harm to anyone. Now, when we think about law, law is about standards that are set by the government. They are enforced by legislation. They establish responsibilities of the health provider, secure the interests of the patient, and it sets down a set of rules. These rules are under two main headings. They are civil or criminal. So ethics, however, is linked to law, but it is of a different texture. It is about human behavior. It is about morality. It is about moral values. It involves motivation based on what is right and what is wrong. It is about good versus bad. It is about what is more important, what is less important. And the professional ethics are used as a basis sometimes to help you, to help to make the law. Now, what does ethics comprise? Ethics, there are many criteria under which ethics is addressed. You have autonomy. That's the right of the patient interest. It is about getting the patient to consent. Now, in Trinidad and Tobago, we have a situation where in the early days, you go to the doctor, he sees you, and he doesn't tell you what is wrong with you. If you ask too many questions, he would feel that you are questioning his knowledge and you are questioning his capacity. This is not so anymore. Consent, getting the patient's consent to take any decision that you are making in his or her interests is critical. And in order to effect a consent, you must be able to give the patient information. They must have the knowledge, the capacity the mental capacity. You have to explain the procedure. Tell them about the treatment. What are the side effects of the treatment? What is the harm that is involved? For example, if you are telling somebody about smoking, you will need to tell them that it's an addiction. Otherwise, they wouldn't the difficulty that you would have in discontinuation, in stopping smoking. For example, how you tell the person is important. Let's suppose you want to give somebody a blood thinner, and the doctor tells the person, well, you know, they also use it in rat poison. It is unusual for the patient to accept that. If you tell the patient, well, you know, it's a 50-50 chance, and the person has gangrene of the leg, they may say, let me die with both my legs. If you tell them as a surgeon, I haven't crippled anybody yet, it would almost determine the decision that the patient would make. And some doctors actually use this mechanism to ensure that the patient, especially in the clinics, they ensure that the patient does not agree. And then they would write on the notes, patient refused procedure. Now, when patients also refuse, so for example, somebody may refuse chemotherapy, there may be religious issues. You learn to explain. Right? Otherwise, some people, what you don't do is to disconnect yourself emotionally from the patient. And they say, oh, you don't want to do it? Okay then. Or okay, that's all right. The patient to decide there's a right to die. Children, in Trinidad, the age of consent in children is 18 years of age, and that also has to be respected. Now you would find that a lot of the time these days, patients would be reading up on the internet. They'd be reading on the internet and they would look and they would see side effects. So they would say, doctor, I wouldn't want to take that tablet because it's a side effects. You would need to explain to them why they should take the tablet. But you need to understand the culture, and you need to and be able to talk and explain to the patient. Right? Because research into a matter doesn't necessarily give them perspective. So for example, if somebody talks about side effects, you may want to tell them, you know, I ask them sometimes, how are you going home? And they say, by car. I say, what is the adverse effects of going home by car? Well, I can get killed. Okay, so that is one of the side effects. Doesn't it mean you're not going home? So in a way, you engage with the patient in the culture so they will understand. You may want to tell them, don't run from a dog and get hit by a truck. All of this addresses the requirement to make decisions in his or her interest. Secondly, there's a word they call beneficence. It's really just about acting in the best interest of the patient. Sometimes you will find that you will have referrals to colleagues And it is wise to refer to colleagues to get another opinion in the best interest of the patient. Leave your ego at the door. For students, the students should not find themselves placed in the middle between senior colleagues. You find you'll end up sometimes in situations where there are poor competence with your colleagues. And you must be able to subtly speak to them with understanding and respect. In a situation like that, data is important. In my own experience, the criticism of a colleague is not sometimes easily accepted by others. And it is wise that you have the requisite data. Further, in our environment, you would find somebody would come with some illness, and you would hear of them getting an appointment for December 2022. In law, that says res ipsa loquitur, it means that speaks for itself. Sometimes you may have somebody who had a possible cancer of the colon, and they may get an appointment for 9 months later. Those actions could not be considered to be in the best interest of the patient. Now, what you would find is that sometimes as a young doctor, somebody would meet you and they said, you know, I have this chest pain. What do you think I should do? It may be a heart attack, but if you give advice and the person dies, it would be said that you gave advice and that they had consulted a doctor. So be wary of corridor consultations. Even as a student, you may have family members who may come to you and ask advice. Be wary of that. When I was a young doctor and I did social and preventative medicine and I went to Mandeville in Jamaica, at the university, I was a student. When I went out into the country, they all started calling me doctor and referring all sorts of issues, of matters over which I knew nothing to me. One has to be very careful about that. The third aspect of ethics is do no harm. You may end up in a situation whereby you have to give a blood thinner to somebody who is vulnerable to bleeding. They may have pouches in the bowel also. These are significant decisions. Ask yourself, do no harm. But do not harm to the point where you're really practicing defensive medicine, where you're really protecting yourself if, for example, the person, if something happens. Issue of justice, right? Now we have a little situation in Trinidad where we have a public system and a private running in parallel. And therefore, what you find is that sometimes the private system can benefit if the public system does not work. I hope you all are hearing me. Who gets treatment? The distribution of scarce resources, coronary angiograms, no beds in the ICU, system of accessing the capacity to pay for private care which is unavailable in the public system. When I was a younger doctor, in fact, most of what was at the cutting edge was in the hospitals. Changed. There is also the issue of dignity. I have an aunt who is 107 years of age, and there's a tendency in our environment to discharge patients and saying, oh, they have lived their life. They have lived their life and they're doing, you've reached 70. And well, yes, death is normal. Please, every life is important and at whatever age. Truth and honesty. Always tell the truth. Don't promise what you can't deliver. Somebody has cancer of the pancreas that can only be addressed with chemotherapy. You will explain it to them and tell them in the most comforting way possible, but speak the truth, but speak with compassion and understanding. Now, there are sometimes you're supposed to, there are times you have to respect confidentiality, and there are times when there are exceptions to confidentiality. You've got to report to see gunshot wounds, fitness to drive, violations of the Sexual Offences Act, refusals to tell a spouse that you have HIV, abortion in underage children, statutory rape, situations where parents don't agree to vaccinations, disagreements, communicable diseases, medical board, police, audit. All of these are exceptions to the confidentiality rule. Now, there are areas in which both the law and the ethics overlap. You do something to a patient without their consent that is serious, and you are vulnerable to assault and battery. This applies also to students, and I will explain that more later on. If you breach confidentiality, you can go to the court, you can be put before the court for breach of trust. Failure to report, you can be charged. Abortion, unless you do it in Trinidad without considering the physical and mental health of the mother, it is otherwise illegal and you can be charged with manslaughter. Euthanasia, killing people just because they're very ill to relieve them of pain, is not acceptable here. And I don't know, you all would not necessarily remember the brain death issue, which occupied Trinidad and Tobago, which I had to look into. The problem there was the doctor had gone in the night and turned off the ventilator of this patient. He acted clinically properly, but he had not spoken discussed the matter significantly with the family, nor with the nurses who were present at the time. It created quite a problem. I want you to read the medical broad practicing guidelines, the ethics guidelines, and also issues involving governmental regulations also apply. Another area is conflict of interest. Do not split fees. You have a referral, it comes in, you don't take money for that. You don't share income with labs and x-rays. You don't favor drug companies because of gifts. And you don't have a sexual relationship with a patient. Now we come to the law. If you see a patient and something goes wrong, you can be, a writ can be filed in terms of negligence. Negligence, we are now on the law element, negligence. It is a breach of the appropriate standard of care. What is this standard? A doctor is expected to act in accordance with the practice of a proper and responsible doctor. a reasonably competent doctor in that field. So if you are a student, there are standards you have to follow too. And you would find that at the end of the day, those are the standards that a court will determine whether you are guilty of negligence, whether you operated to the standard. A specialist will be judged on the basis as to whether his standards were consonant with what is expected of a reasonably competent specialist in that field. So what are the criteria? First, the court decides, is there a duty of care? Meaning, do you have a duty owed to that patient? The family doctors, you would have a duty to your patients. You're seeing patients in the hospital, you have a duty of care. You have, if you're a hospital, from the time somebody comes to a hospital, it is presumed that a duty of care starts as soon as you arrive at the casualty or the hospital. If an ambulance, for example, accepts a call and comes and is appropriate, a duty of care arises. However, what is interesting, let's suppose you're walking in the road and somebody falls down. Ethically, you have a right, a duty to take care of that patient. But if you took care of that patient and was negligent, you do in fact, create a duty of care to that particular patient. Now, the breach of that duty is the second element of it. If you don't meet the standard and you breach that duty, then you will find that you will be held liable. Now, let's take students come in. There is a little special element of the law which I want you to think about. Once you are operating as part of a team, so you see the normal teams in the hospital, you're part of the medical firm, you know, the consultant, the registrar, the house officer, the intern, and the student. You are part of that unit. And the law says that if you do anything, you of that unit, and you have to take responsibility for anything that happens that falls below the standard of care. Whether you are a registrar, whether you're a student, whether you are the intern. And that the only way you relieve yourself of that duty is if you pass on the responsibility beforehand to somebody of a higher competence. This does not excuse you. And therefore, students have to be very careful that they do not undertake treatment or in different procedures that are outside of their competence and they are not appropriately supervised. There is a case I want you all to look at on the net, which is Adiza Babwa Gaba, Medscape, on the 6th of February 2018, Dr. G-A-R-B-A. But you just get us looks at this. And you'd understand also the vulnerability of junior. Sometimes junior doctors and students find themselves before the court while the consultant is not charged with any responsibility. because either the patient wasn't sent to him or otherwise. Hello? Now, damage, a harm must be done. Hello? Have we lost connection?
No, Prof. Please go ahead.
Go ahead, right. Thank you very much. The damage, we need to talk about damage. That's the third criteria. Harm must be done. It's called damage. What it means is that people do things that are wrong all the time. But many a time, what we do that is wrong doesn't cause harm. To be harm, there has to be some damage for there to be a cause in negligence. And another thing, you may find that something has happened to the patient that is unrelated to the negligent act. In that case, it would not apply. So that the negligence must make a significant and material contribution to the harm that occurred. Also, you may find that something may have gone wrong with a patient. And that patient decides, look, I am discharging myself in the hospital. If something happens to him as a consequence to his discharging himself, it means that you get a break in what you call the chain of causation. He has now to take responsibility for what happens to him after that. Now, remember, essentially the court ends up as an arbiter between the experts on one side or the other. There are other alternatives which we need to consider, which you will find mediation and so on, which might better assist the patients, because it's very costly and it's very difficult to get doctors to give expert witness. The next thing I would want to tell you is that when you have two elements, two ways of doing something. So let's suppose, for example, somebody is having surgery on their prostate. Years ago, they would still allow aspirin. Some people would operate when they were still on aspirin. Some people may not operate or remove aspirin, stop aspirin before they did the surgery. Once there are, the medical profession allows for different ways of doing something, no liability arises. Now, and then we come to criminal negligence. Criminal negligence is when you go to court and you can go to jail. This is negligence that is extreme. The previous one is about damages. People, you pay money for making these errors. However, what I want to tell you is that even though the court may say this, the importance of the institution to hold doctors accountable internally. And the criminal negligence is a negligence that is beyond inadvertence. The gentleman, you were called as a doctor, you had a heart attack, you are seriously ill, or you had appendicitis, you need surgery. The doctor knows about it, but he decides to go and play golf and decides to come afterwards, after golf, and after he's finished his 17 or 18 holes, and then comes to operate and the patient dies. That's an example of criminal negligence. Now, the last aspect of this little talk, which I tell you is, you don't try to remember the details, all the details. It is to give you just an insight and a feel as to what is required as you go through your medical journey. I want to share with you some of the practical applications of law and ethics, which I have found very important and have application not only to medicine, but to life and living. And I would want you to sit down and to consider them very seriously and incorporate them into your value system. Number one, seeing about yourself and thinking about yourself and thinking about what is in your interest is a natural survival instinct. You learn objectivity and you learn how to think logically by practicing it daily. And this is one of the elements that the pursuit of a science like medicine can inculcate. Don't miss the opportunity. It teaches you not to trust not only feelings, but to cultivate respect for science and data. Now, if you want any example of that, think of COVID-19. When the government decided that you were to stop going to beaches and so on on the Monday, and they told on the Friday, many people ran down to Maracas and said, listen, we understand, yes, we agree, but we just wanted to take a little dip before the Monday morning and the time start. Just think about that. Think about that process of thought. And people, you're asking people die in war and put their body on the line, and we ask them to wear masks, and that is just too much. Next, the discipline you exercise is what will work for you in a crisis. This is also about Trinidad. It is about the discipline that we demonstrate in the country on a daily basis, that when we now have a COVID crisis, we have not all really got accustomed to practicing that discipline. And so we now complain of how people are not wearing masks. Next, if it works for everybody, it will work. I worked at Sangre Grande for many years. Everybody knew me. But I haven't been there for many years, 16 years, lots of years. If I'm traveling to Tokyo and I get in an accident, and they bring me into casualty, nobody these days knows me. It is the system that works for everybody that will work for me. If we try to have blood for everybody, they will have blood for me. So the ability to think long-term and realize that you don't always necessarily do somebody a favor by dealing with everybody. The two main elements of life are making a living, which is certification, and winning in the school of life. Good relationships, positive community relations, and participation. You need to invest in both to be happy. Responsible elites pursue the public interest even as they pursue their self-interest. And in my time, medicine was a hierarchical system. The consultant was the boss and everybody else was somewhere lower down. One of the things that struck me when I was in Canada was how they encourage students to be assertive, to ask questions, to give their point of view. So we need to also, maybe it happens now, but I would just make the point that it's important to have an egalitarian system that would contribute to an environment of mutual respect, cooperation, teamwork, collegiality, fairness, impartiality, and a pleasing work environment. We need to cultivate an environment of learning without tears. If you want to teach somebody to swim, you could go in the Atlantic and drop them in the ocean, and I suppose they will end up to be a very strong swimmer. Or you could take them into a pool and show them how to swim. Because the product of the process by which you learn has a long-term impact. And that long-term impact can be gratitude and commitment to UWI and the society. Left, you would be giving support to the university and to alumni. So students need to learn to work together, share information, discuss and debate medical issues. It helps retention, but it nourishes the environment. It nourishes camaraderie and mutual respect. Accountability for all fosters an environment of cooperation. When I went to Canada, I was surprised how everybody was following the rules. You didn't understand how they would talk to one another. They would ask for opinions. And then you realize that they all understood that when they did that, they were protecting themselves because the system held you accountable. Quite apart from the care delivered to the patient, good communication is important. And many a time, even when you make an error, the family doesn't engage in any litigation because of the relationship and the goodwill that you espoused. Engage the patient in the culture. Give a little chat when they come in. If somebody comes to my office and they find that we used to play table tennis together when we were young, immediately we are real great partners. If we knew somebody, if we knew the same person, if we had been to the same school, those connections are what lubricate the relationship between people. And it helps in dealing with the patient. It is important that you support reasonable rules and guidelines of the institute. Only do they offer you guidance and protection, but they provide an objective basis and a fair process for your own evaluation. Lastly, proper documentation in the patient's notes is critical. You need to write down what happens, anything that reflects what occurs within reason, as you would learn along the way, students, as it is the major legal record of the patient's care upon which the court depends. What you told somebody and what somebody said when they were finished seeing a patient does not help you in the court of law. And so, after you've graduated as a medical doctor, before you a world that awaits your competence and a world that awaits your guidance. All I can tell you at this early stage is go brave. Thank you very much. Hello? Hello? Yep. Okay.
Okay, Dr. Pear, we would like to thank you for that presentation and enlightening us on first-year prospective students and the healthcare professional, the significance of ethical and legal issues for future practice. Up next, we have Dr. Deborah Pinder. Dr. Pinder is an ENT specialist with a particular interest in audiology. She works in the Ministry of Health as a medical consultant in audiology services. She's going to present on communication issues of the deaf and hard of hearing and introduction to sign language. She is also assisted today by Dr. Rianne Hutton, who is a medical doctor whose first language was sign language. She is a sign language interpreter with the Trinidad and Tobago Health Hearing Impaired Association. Dr. Pinder, I now present to you.
Thank you. Good day.
Dr. Pinder, unmute your mic. Your mic is muted.
Good morning, everyone. My name is Deborah Pinder, as I was introduced before. Officials of the University of the West Indies, invited guests, first year medical and dental and pharmacy and nursing and optometry and nursing students of the Faculty of the Medical Sciences, University of the West Indies. On behalf of the Ministry of Health, I'd like to thank you very much for inviting us, for inviting me and our team to participate in this online orientation session. And I wish to thank as well the University of the West Indies for recognizing the importance of our particular topic and for the students of the Faculty of Medical Sciences. I am a graduate of the University of the West Indies as well, Medical Sciences, and I graduated in 1982. So without further ado, I will just go on to my presentation, which is a PowerPoint presentation, and I'm just going to share the screen with you. Okay, just excuse me while I just get to the beginning of this. Okay, can you see me at all? No?
Yes, we can.
Can you see my screen? Is my screen coming up or not really? Okay.
Yes, it is.
Okay. Okay, so this morning we're talking about communicating with the deaf and hard of hearing in a healthcare setting, but not necessarily only in a healthcare setting, but in other settings. Can you see the PowerPoint presentation?
Yes, we can.
Right, great, okay. So as has been introduced, we have team members. Apart from myself, we'll also be having Dr. Rayanne Hutton and Ms. Castriba Lafleur, who will introduce themselves a little further. So why is hearing so important? Well, the main reason is really because of its role in human communication. And that's really, really important, as Dr. Pear was talking about. He spoke about a lot of things in terms of communication, speaking to your clients, etc., etc. But this is really, really why this particular topic is here today. So communication is the foundation of all human relationships. It allows for expression of our thoughts and feelings and helps us to understand those of others. The main method by which almost all of us, all humans communicate is through verbal language. That's speech and written words. So let's just go in to see why our hearing is so important. For socialization, we want to go and we want to meet our friends at a normal place down in the village or wherever we are, we're going, we're liming, we're talking. That is how we are communicating. That is how we're sharing what the news, how everybody else is, etc. We want to go and talk about to our children about really, really important matters. We're sitting down. The main way that we are going to communicate with them is through verbal, through speech. And that is, they are listening, we are speaking, they are speaking, we are listening, we are understanding them. You are now at University of the West Indies. This whole orientation so far, how have you been really finding out what everybody else is saying to you? It's really by verbal communication. You are listening on YouTube. That is what's happening. Persons are speaking. I am speaking. The presenters before were speaking. When you go into your various classrooms and lecture halls and so on, that is the way that we are going to be communicating information to you. Some of us here are going to be nurses and will continue to be nurses. When you're talking to your client, you're going to you'll be speaking to your client, and you do so with speaking, with verbal communication. You may become a dentist. You want to take a history, which is what Dr. Pear was talking about before. You want to talk to your clients. You want to tell them about different risks, etc. This is how we do it. Now, I want you to look at this picture here. And just look at what everybody, we are people of faith, very in Trinidad and Tobago mostly. And we are, look at this. Everybody here, what is everybody here doing? Every single person here is actually speaking, and others are listening. So this, basic, fundamental communication. Somebody's telling you something very important. Your doctor is telling you something very important. You want to listen. This is an operation. You have to have an amputation of your leg. That's a really important thing, right? Or the pharmacist or over the counter, you're telling the client you must not use this particular medicine on an empty stomach, or whatever it is. Or you're saying, if you have any side effects, you need to come back and let me know. All those things are how you need to communicate with the client. And this is our main way in which we communicate with each other. So also enjoyment and relaxation and safety. So basically, as humans, this is what we really do. So really, how common is hearing loss, and how many of your clients are you going to, encounter with hearing loss? This is a chart by the World Health Organization, and it shows the prevalence, in other words, how frequent disabling hearing loss is among adults in our region. So we are in Latin America and the Caribbean, and we're looking at about 8% of our population with a problem like this, about our adult population. So what does that translate into Trinidad and Tobago? That means about 110 persons in Trinidad and Tobago have a significant disabling hearing loss. Now, many of these people will just be hard of hearing, so they will have difficulty understanding words, but that's how they will communicate, by speech. So that translates into maybe 1 in 12, 1 in 13 persons. So a number of your clients are going to be challenged in this way. So it was also estimated that in 2011, that in excess of 7,500 deaf persons were using sign language as their main and only really method of communication. So that you are going to get a significant number of persons coming to you, whether you're a pharmacist, whether you're a nurse, whether you're a vet, whether you're a dentist, whether you're an optometrist or a medical doctor. A number of persons are going to present to you with hearing loss. We know that the quality of healthcare delivery is negatively impacted by poor communication. That is quite clear, and that is a fact. As healthcare providers, we all need to be able to communicate effectively with our clients. And we know, and we've established that speech is the main method that most humans use to communicate with in everyday life. Our ability to hear well is necessary for understanding speech, and our ability to hear is also necessary for us to be able to learn to speak. So as healthcare professionals, and as students of, as you are coming into these professions, you are already embarking in the first phase of your healthcare profession. So as healthcare professions, all of our professions are intrinsically helping professions. So the primary purpose of which we are here really is to serve the needs of our patients and clients. And persons with hearing loss who come to us have significant communication problems in the healthcare system globally, as well as in Trinidad and Tobago. So therefore, it is our duty to minimize these problems as far as we can. And if we are able to help them as much as we can. So if we want to do that, if we want to help them, we have to minimize their communication problems. So a few terms before we go on. So when we talk about deaf, you notice that one is with a capital D and one with a small d, and we may go on to that a little later on. A deaf person is any person with very little or no functional hearing, which can be used to decipher speech. So persons who are deaf will generally not be able to understand speech or will rely on other methods to communicate. And generally, a lot of deaf persons who rely and use sign language as their only or preferred method of communication, they're usually born deaf, meaning they're significant, they have very, very little hearing, or they may become deaf very early in life. So their method of communication with you would not generally be speech. You'll be speaking to them and they will not understand what you're saying. Hard of hearing persons, however, are generally persons who don't hear well, and it varies. It could be, they can have a moderate hearing loss, a lot of mild difficulties understanding speech, or it may be quite severe. But they generally have varying levels of understanding speech, but they will still use speech and writing as their main method of communication. So when they present to you, they will present to you with, you will have to, will speak to them or write to them, but they will be communicating mostly with speech. Deaf and hard of hearing persons will generally feel much more vulnerable in a healthcare setting than persons who are hearing normally. And it's an analogy, for example, let's say you are traveling in Mongolia and you fracture your ankle, you break your leg, and you end up in a hospital. You don't have a cell phone, you can't speak the language in that hospital, and they can't speak English. Think about how you would feel and how what sort of threatening situation that would be. So that's something of what maybe a deaf person who ends up in a hospital situation may be faced with if they don't have somebody who can translate for them, and you don't know sign language, or you have a lot of difficulty communicating with them. Or for example, a hard of hearing person. Let's say that you go to Venezuela and you were in a car accident. You know a few words of Spanish, but you really can't follow when the person speaks to you in fluent Spanish. And that is the sort of thing it may be like that if you are hard of hearing and you're really having difficulty hearing persons and understanding speech to a certain amount. So how do we spot someone who's not hearing well? It is usually very easy to spot a deaf person who's trying to communicate with you, because that person would have no or little speech. They may produce really strange high-pitched sounds, or they may attempt to sign when they present it to you. it may be more difficult to spot someone who's hard of hearing. That person may not want it known that they have a hearing problem. They may feel embarrassed, or they may not even realize that they're having a significant problem with hearing. So what I'm going to do now is talk to you about some signs that a person is hard of hearing. So what sort of things that you may notice if that person has a real difficulty with hearing? They may ask you, they may frequently ask you to repeat what was said. They may have inappropriate answers to questions. For example, you may ask, okay, so how long are you having the chest pain? And their answer may be on the right side of my foot. Totally inappropriate. So you know that they are not really understanding what you're saying. So it might be that they are not hearing. They may turn one ear to face your face, tilt the head. And so they're looking at your face, but they're actually trying to put their ear towards you. And this really is usually a sign that somebody is really hearing better on one ear than the other. They constantly look intently at your face when you are speaking. If you see somebody, a client, just looking at you all the time, focus very, very strongly on your face when you're speaking, that might be that they're actually trying to read your face to help with their hearing. So they're actually face reading, they're lip reading, and they're looking at your face intently so they can understand what you're saying. Deaf persons do this as well as persons who are hard of hearing, who do it automatically. They may not realize that they're doing it, but they do it automatically. And some persons, abnormal pronunciation. And usually this indicates somebody has a significant hearing loss from a very young age. And today you will hear somebody who would have that particular problem, and you will hear, somebody might speak something like that. They speak like that. That usually implies that, may indicate that they have a hearing problem. So what are some of the things that we want to do to make sure that we connect and communicate as well as we can with somebody who has a hearing loss? One, make sure the person can see your face when you're speaking. Most persons who are hard of hearing automatically use face reading, as I said before, to help them hear better. In these times of COVID, we can maybe remove the mask, but put a face shield in so they can see through when you are speaking to them. You ask the person, as I said before, if they hear better in one ear or on the other, and position yourself so you are nearer speaking to that ear. So this nurse here is speaking to this client on her right side because she's not hearing as well in the left ear. Very important, say their name, simply say the person's name at the beginning of a conversation so they know you are speaking to them. So for example, you may be there with a client, with somebody else and others in the room, and you may be talking. They may not know that you're actually addressing them. So you start, Miss Mirage, what has brought you to the hospital? That Miss Mirage will alert the person that you're talking to who. Keep the background noise to a minimum. So for example, maybe when you're in the vet school, there are a lot of animals barking, etc., and the animal's human is trying to tell you what is happening, but they can't hear. You try and move away from the noise, move to a quiet area. If you're in a room, try and close the door. Just make sure that you are in a quiet setting because they will hear and they will understand you better. Speak slowly and clearly. You can speak a little louder than normal. You ask if they have understood. Say it in a different way if you're continually asking the same thing and they don't seem to be understanding. So for example, you ask them, do you have a pain in your hand, or show me where the pain is? You can say, okay, show me, and you can point. Show me where's hurting. Say it in a different way. Don't shout. Very, very important. Don't shout. When persons with hearing loss often hear sounds in a distorted manner, and shouting makes this much worse. So you can go nearer, you can go near the ear and so on. You can use gestures, You can do other things, but don't shout. Don't talk from one room to the other or with your back turned. Keep your hands away from your face when you're speaking to the person, because a lot of persons, as I said before, they use your face to help them hear better because they look at your words and your facial expressions. Have a pen and paper ready to write simply and legibly, especially with deaf persons. Their English and so on may be, and their written understanding may be problematic. So it's really very important to be very simple when you're writing and to write legibly, and just keywords when you're writing. No long involved sentences, keywords, and it has to be legible. So that is really, in a nutshell, what we are trying to do to communicate better with our hard of hearing persons. And I'm going to put you on now to Dr. Ryan Hutton, who is going to go and talk to you about the introduction to sign language first. Okay, thank you.
Okay, good morning, everyone. I am just here to give you a practical insight on sign language. And when you become healthcare workers, a doctor, nurse, pharmacist, veterinarian, dentist, you'll be able to better communicate with a deaf patient when they walk in, okay? So I'm gonna start off with a little story. All right, so a year ago or so, my father, he had a DVT, a clot in his leg. So he went to the doctor, he was hospitalized for a month. And then when he came home, I realized there was one thing different about him. Now, he has been hospitalized before. This is not the first time he's been hospitalized. But this time I'm noticing something much different in his demeanor, which is he's actually being compliant with his medication. So I asked him, why are you being compliant with your medication? Now, a background story, my mother and my father are deaf. So I'm asking him, so how come you're using your medication this time? He said, well, the doctor actually explained to me what is going on and what's wrong with me. And now I understand the need for taking my medication. And I was like, what do you mean the doctor spoke to you? The doctor knows sign language? He was like, no, the doctor doesn't know sign language, but he tried to communicate what was going on. I got a little diagram, etc. And he felt like, okay, now I feel the need to take my medication. So when you expand your communication, it really helps you maintain that doctor-patient, pharmacist-patient, nurse-patient, whatever relationship you have with your client, helps to maintain that relationship, and it encourages compliance. It also helps with better diagnosis and treatment, because sometimes you're able to figure out how often this has been occurring and help you to come down to something more specific which could help that patient, right? So today I have you for a few minutes. So it's not going to be practical of me to say that I'm going to just teach you sign language and then you're going to be able to talk to the next deaf person that comes in. What I'm going to do, I'm going to make it a little interesting. I'm going to give you 5 formal signs, just 5 signs, formal sign language. And the rest, you are going to tap into your innate ability to use gestures, lip reading, and pointing, and certain ways. This your innate ability to sign. You're going to use that to communicate with a deaf client next time you see them. Because most times when a doctor, a nurse, whoever, oh, the patient deaf. That's it. They're just stuck in their tracks. And they just work around the client. You work around them. Half the time they don't know what's going on. You don't even understand what's going on. You try to write this long, wordy paragraph. They can't read it. Because imagine you had to learn Spanish. You had to learn Spanish and you have never heard someone pronounce this Spanish word to you. And you yourself can't even hear yourself pronouncing your word. You're reading a sentence. You could see, maybe you can't see how a sentence is being structured, but you cannot understand a sentence. You can't read. When you read, You read in your mind, you hear your voice reading the words in your mind. Imagine you cannot even do that. So this is the life of a deaf individual. So when you write these long wordy stuff, it's going to be hard for them to understand. And you have to tap into that ability to break things down simply. That's the first point. Break things down simply. When a client comes in, you're not going to say, what brought you here today? You're going to have to break that down even smaller. So I'm going to show you now how that goes, right? So with me, we have my mother. My mother is deaf, right? She lost her hearing, a lot of her hearing from a very, very young age. And throughout her life, she was given, some informal speech therapy in a kind of way, to help her learn to pronounce certain words. So she may sound a bit more advanced to some deaf people. It's a whole spectrum. But my mom is here to go through some scenarios with me and with you as to when a deaf patient comes in, what do I do? And I'm going to go through firstly the five formal signs I'm going to teach you that will help you take a good enough history to understand what is going on with your deaf patient. So the first word I'm going to teach you is the word wrong. Wrong. So you're going to have your palm facing forward. Feel free to join me. You have your palm facing forward. And the 3 middle fingers, you're going to put them down like this. So now you have your thumb and your baby finger sticking out. It's going to go by your chin. Wrong. This is wrong. You'll figure out why I'm teaching you the word wrong. The second word I'm going to teach you is pain. That's a common presenting complaint. Pain. You're going to get your 2 index fingers and you're going to put them together. Pain. This is pain. Pain. And the second point I'd like to make, it is very important, just as I said, as you keep things simple, I would also like you to make sure that your mouth is free. In COVID times, you'll have to use a shield, but the deaf client needs to see your lips. It is not like in the movies where you're speaking just like this and they're understanding every sentence and every word that comes out your mouth. It's not like that. You're going to pronounce wrong. And when you do pain, you exaggerate the pronunciation. Pain. So when the deaf client comes in, if it's their head hurting, their neck, their chest, you're going to see pain. That's his head pain, neck pain, chest pain, stomach pain, back pain, right? So you know what's going on with the pain. The third word I'm going to teach you formally is pills or tablets. You're going to put your index finger and your thumb together, pinched like this, all the rest of the fingers down, and you're going to act as if you're popping a pill. So tablet, tablet, tablet. And your mouth is already pronouncing the word pill, tablet, right? The fourth word I'm going to teach you is one of the common ones you hear in the hospital or in the doctor's setting or pharmacists, etc. Diabetes. Now with diabetes, you're going to stick your index finger upwards, and then the middle finger, married finger, baby finger, and thumb are going to meet at the tips. So you have this hole here. This is D. At the chin, up and down, diabetes, diabetes. So far, I'm going to go a little slower. So far, we have wrong, we have pain, tablet or pill, diabetes, and the last common one that I'm going to teach you, only 5, and we're going to take a history just knowing these 5 signs. Pressure, we're going to do blood pressure, high pressure. So your index finger and your middle finger downwards. Then your thumb in the back here is going to go between them. Right? Almost like a walking man. Index finger down, middle finger down. Behind your neck, pressure, pressure, pressure. Right. That is the sign for high blood pressure. So those are the 5 formal signs you have. Wrong, pain, diabetes, pressure, and the tablet, right? Or pill. So this scenario, we're at the doctor's office. So you say hi. Well, it's COVID times, they can't shake hands, but back when you could have, you know, hi. Okay, she comes in. The first question, instead of asking her, what brought you here today? That's hard. And if my first instinct would be, what brought you here today? Right. She knows what I'm about to say, but at that question, when they come in, they're not going to understand what you're saying. So the first thing you can ask is, what's wrong? What's wrong? Okay. Pain at the head. She's having headaches. Pain at the head. The second question you're going to ask, since there's a pain, you would like to find out how bad is this pain? So I don't know how to sign how bad is this pain, and I would really like to elicit this from my patient. There's something called a pain scale that you will learn about eventually, where you want to ask them on a scale of 1 to 10, how bad is this pain? So I know 1, and I know 10. Let's see what's going to happen. So 1 is okay. 10, bad. 1, 2, 3, 4, pain. 6 or 7. She said 6 or 7, around there. So you take note of that on the pain scale, how bad the pain is. Now I want to know when it started, how long she's been having it. I can assign this. Well, some of us have on our phones a calendar. Some may have a calendar on your desk where you're working. So I have my calendar. So I'd like to know, how long have you been having this pain? Lips clearly asking, how long? How long? Okay, so she pointed at 4 days for me, and it ended up to today. Well, of course, she's presenting with it as well. So just by having my calendar with me and gesturing to find out how long, I was able to find out the day it started, how many days she's been having it for, and I can make note of that now. I want to know, is it constant? Is it intermittent? I can't sign this. Or how am I going to ask this patient? Do not get stumped. Go simple. Gather that innate ability. You can do this. If you want to tell your friend quite so, you're pointing and you will do all the works. Same thing for a deaf individual, right? So, pain, stop, pain, stop, or pain, right through. When I'm sleeping, it's okay. When I wake up, pain, sleep, quiet, wake up, pain. And she said she drink water for the pain. From those little gestures, just pay attention to your client. You'll be able to elicit what exacerbates the pain, what helps make it better, and you can make note of that. You control the pace of the conversation. You control the speed or the amount of detail in the conversation, because you don't understand how to sign, but you do know how to do gestures, and the deaf client will be aware of that. So if you're moving on, let's say we want to know, we're going into drug history. We want to know, you've been taking anything for it? Remember I taught you pill, right? So you tablet. Panadol. Okay, let me tell you yes, no. In her case, she mouthed Panadol to me. Sometimes the client usually walk in with what medication they're already on. That should be easy for you, because they tend to come prepared, knowing that someone may not understand them as well, right? But in this case, she spoke Panadol. I take note of that. Medical history, you want to know, the usual, the two, right? So, diabetes? No. Pressure? No. Okay. So, you have a fair enough history to try and elicit what's going on. Of course, depending on different presenting complaints, there's so much more to gather, but at least you're able to cover the basics with your deaf client. Now, if I had you for a semester or a year, You'll be professionals by the end of it. You could take a history from any hearing or deaf person that comes your way. But for now, with this basic introduction, you can at least cover the basics with a patient when they're taking a medical history. So you have wrong, that's the review. Wrong, palm out, 3 fingers down at the chin, wrong. Pain, pill, diabetes, pressure. Now for my dental students, I know in Mona, they have a sign language course for the dentistry students. Well, right now you're gonna have a little introduction right here, because maybe you remember it 2-3 years down the line when you start your clinicals, right? So the dentist, patient comes in. Patient comes in. Hi, what brought you here today? Right, she knows I'm asking, right? So she knows I'm asking. But sometimes you start talking and the person is deaf and you don't know that the person is deaf. So you start talking, she's like, sorry, I'm deaf. They would indicate to you, right? I am deaf. Okay. So when she comes in, they give her the form to fill out. They give her the form. In filling out the form, okay. For drama's sake, she hit a stumbling block. Diabetes, okay, pressure, fever, right? I didn't know fever, but mouth, fever. She was able to grasp that a little, okay. Now you want to know if she has any pain. That's a common thing with teeth, right? Pain. She just pointed at 2 areas that are really hurting her. So I'm going to ask about that one. 1 to 10. 1, all right. 10, bad pain. Okay, about 10, how much? How much? About 1 or 2, okay. And I take note of that. I can elicit how bad the pain is. So now upon examination, I noticed that she may have to extract the teeth, both of them. You already know. One time, I didn't have to teach you sign language. If you want to tell this patient the teeth has to come out, come out. So teeth come out. So these are things that you probably didn't even know you knew. But in tapping into that, keeping aware of the fact that you have you're gonna have a plethora of patients coming to you. Keep being aware. All these things help with your ability to communicate. It doesn't always have to be verbal. Gestures, hand movements are just as efficient. Once you take it slow and make sure your lips are moving comprehensively. No, I can't say comprehensively to a deaf person, but you know the little words that I was saying, right? How much? What wrong? Teeth has to come out. Okay, so in continuing with the dentist scenario, we tell her that the teeth has to come out. Maybe you do it right there and then. So you tell her, now, take out. Or if she has to come back at another time, you come back and you pull out the trusty calendar, know when, or you always write the date down. That will be easily understood by a deaf individual. Let them know what date they have to come back. If you want to prescribe something for them in the meantime, or the tooth has come out and you want to prescribe something, here's where my dentists and pharmaceutical students, here's where you all come in. So either you're writing the prescription and they have to now present it to the pharmacist. So she's entering to the pharmacist's place, the office, and she presents the prescription. Okay, so the pharmacist put together what is needed. I hand it to her and it has the directions on there on how to take it. Right. As language, okay. As language being a barrier, she wouldn't understand. So you can tell her 1 with breakfast, 1 with dinner. Simple. Break it down for them to understand, right? So that is a wrap on everything. I would just have my mom say 1 sentence for you to see how when you're unable to hear anything, how it could affect your verbal communication. All right?
Hello, I'm Marcia Hatton. I live at Elmwood. I have 3 daughters, beautiful daughters. Leanne is my lovely child because when she was a baby, I took her t-shirt. And other 2 girls, I teach them too. And I would like to tell you, you can help deaf people. They need to understand clear. You have to show them, make sure they understand clear. Thank you very much.
All righty. All right, so now we have Miss Kashiba Lafleur, who would take on from where I left off.
I had to go through the process of trying to figure out my computer on Zoom. I do apologize. Good morning, everyone. I'm Kashiba, a parent of a deaf child. One of the things that I, as Dr. Pinder would have been saying, and Ray, and I think one of the things you, as practicing MDs and pharmacists, nurses, medical personnel should know is that in the field of sign language is a real language. And for most deaf persons, as Dr. Pinder would have explained, the 7,500 of those who are dependent on that language, it's real for them. As Rayanne explained a little while ago, most of the times gestures usually helps in the instance if you are unfamiliar with formal signing. As a parent of a deaf child, I would have had a lot of experiences in taking my son, not just to the hospitals, but to private doctors to help him along the process of, to help them understand what he's saying. Now that he's an adult, because he's now 22, I'm no longer allowed in the room. I'm no longer allowed because he's now an adult, but for another reason is that more and more persons like yourselves are starting to be familiar with learning sign language or understanding the need of learning sign language. So prior to now, I would have had to be in the room with him for every single process, where from entry, we would have to explain his name and all those things to the person's taking, the clerk's taking the administration information and going into the doctor's office with him to explain to the doctor what was happening with him. And as Rayanne would have explained, most times once somebody knows that the person is deaf, they kind of like freeze up. Some of them, if you have a person that you like, I used to go with my son, because I go with my son, they would have talked to me. What I would recommend for you guys is if a child or a young adult or somebody comes in to see you and they're deaf and they do have their parent or an interpreter present, please communicate with that person. Communicating with the person who brought the deaf person in makes the deaf person feel as if they are not in the room and you're not really speaking about them. I'm speaking to them, but about them. So you need to communicate directly with the deaf person. Even if you do not know sign language, the individual there with the deaf person will communicate to them and sign. And you are just the one asking the questions to the deaf person. In the instance of my son, I would have explained that to many doctors, and we would have visited a lot Mount Hope or Chaguanas health facility. And after a while, the nurses were familiar with him. So because he is asthmatic, and he's one of those we call high risk, who at the time of COVID right now, we have to be very cautious with him because he has a compromised immune system. So when he goes into the health center, some of the nurses already know him, so they're able to communicate with him. And some of them, on the first instance, one person would have put me out of the room saying, well, he's big enough. And then I said, he's deaf. Do you understand how to communicate with him? And she said she would try, but wasn't able to. So I had to get back into the room. But from there on end, because some of the nurses, the shifts rotate so often, some of them got familiar with him and they understood what he was saying after a while. So it was not necessary for me to be there with him all the time. But I think one of the most things that as doctors or medical professionals, pharmacists, doctors, nurses, whatever field you're into in the medical arena, it's important for you to understand to communicate directly with the deaf person and not communicate with the persons who are there with them as their additional supports. I would have gone with my son as the mother of the child because I was concerned, but also I'm the only person at the time in our household who could have signed to communicate with him. And I remember at one particular time, my son would have gone to the doctor. It was something private, I guess his first encounter with girls. And he just didn't want me to know what he was discussing. And he asked me to leave the room to communicate with the doctor. The doctor was not able to understand clearly what he was saying, but he didn't want me to know what he was saying either. And I had to explain to one of the nurses who was very polite. She understood the situation. I explained to her what was happening. I told her what to sign, and she was the one who was able to communicate with the doctor on his behalf, explaining whatever the situation was, because I knew or had a suspect what the situation would have been. But in all and on, in communicating with a deaf person as a parent, some of us as parents would, we would be forceful and want to be in that room. It's important for you as well as the doctors to find out from that deaf person if they are comfortable with the parent or the other person being in the room with them, because they have their own privacy. They're entitled to their privacy as well. And if they do not feel comfortable with a parent being there to have that conversation, or the interpreter, whoever came with them, to know their business, as some people would say, is their right for the person to leave the room. And as the doctors, though I may come with my son or somebody else may go with him as saying that they're there to help him or interpret for him, it's his rights to say, you know what, I don't want them here, or I don't need them to know. And you have, you can always ask, do you want the person to stay? You want them to stay, yes or no? And if they don't, then you ask the other individual to leave the room. As Ryan would have explained just now, it's not quite difficult to communicate with deaf persons. And I'm certain some of you will have the experience if you haven't had it as yet. It's very easy. And deaf persons, once they know that you do not know sign language, they do their best at trying to ensure you understand what they are trying to say. Like Ryan's dad, Ryan's mom and dad, they have a lot of speech. But a number of deaf persons may not have the opportunity or did not have the opportunity to attain so much speech. But you as the doctor or the medical professional can actually work with that deaf person, just asking simple questions, writing simple sentences, nothing long and tedious, and write eligibly, because I know doctors usually write a kind of way now. They write a kind of way. So if you write eligibly for them to understand just your name, what's the problem, or where hurting, simple questions or simple sentences will get them to answer you. And as Ryan was explaining, just the 1 to 10 count will tell you what threshold of pain they're in, or where actually is hurting, where is the pain, and they would show you exactly where that pain is. And then you would be able to actually give them a better diagnosis on what their problem is. Knowing if they need to do bloods or whatever, take their blood pressure, whatever it may be, you would be able to get a better understanding of that to give them a better diagnosis, so that we would not, in the back end, continue to hear the challenge of that person saying the doctor gave me the wrong medication or the doctor didn't understand me. So as a parent myself, I want to commend you guys, commend the profession for taking this initiative and wanting this, putting this as part of your training. And I really want to say I'm happy to see this is happening, and I commend you all. And I do look forward to being a part of more sessions, especially when we're teaching you a good sign language program. So I think that's it for me on my end. If you have any questions, you can ask. If not, thank you.
Hi, Ryan. Sorry to disturb, but we're not hearing you.
Rihanna, your mic is muted. We aren't hearing you.
Are you hearing me now?
I am, yes.
So thank you again to Dr. Pinder and her team for that excellent presentation. Up next, we have learning skills with Dr. Beryl Simmons. Dr. Beryl Simmons joined the Faculty of Medical Sciences in 1995 as a part-time lecturer in the School of Pharmacy. In 1998, he was appointed a full-time lecturer in toxicology in the School of Veterinary Medicine. He has lectured to students in the BSc Pharmacy, MBBS, and DDS programs, as well as tutored students of these programs in the DDS program and the problem-based learning program. He has served on the curriculum committees of several programs within the faculty. Dr. Simmons, welcome and good morning. Hand over to you.
Good morning, and thank you for your kind introduction. Are you hearing me? Are you hearing me?
Yes, we are.
I just want to Good. Right. Good morning and welcome to all our new students in the faculty, the new MBBS, DDS, DVM, BSc Pharmacy, BSc Nursing, and the BSc Optometry students. One appreciates that this is a particularly challenging time that you have joined the faculty in, but I trust that you all have the pioneering spirit that's going to be important in treating with these challenges. I'm going to speak on the topic of learning styles. And ultimately, I'm hoping that at the end of this session, each of you can answer the question, what's your style? If you have not already done so, those of you who may have looked at this particular question would, I hope, come up with perhaps a refined concept of what your learning style might be. Now, the learning styles can be defined as the different methods that people employ to learn, integrate, and ultimately understand any new information. Learning style, therefore, are the ways in which a person takes in information, goes about understanding, explaining, as well as remembering that information. And remembering is important because at the end of the day, all the information, or certainly a significant part of that information, is assessed so that the teacher can validate the learning experience and certify that you have in fact adequately absorbed and understood the messages that were conveyed. the learning styles can be variously categorized. And I'm going to start very basically by using 3 categories. One would be academic, in terms of the benefits. So one benefit would be academic, another would be personal, and the third would be professional. So in terms of the academic benefits, from the top, maximizing one's learning potential. If you know your learning style, then you are able to minimize the effort that's put into learning while maximizing the outcome of the learning exercise. And of course, that would lead to academic success. You can adapt your techniques so that you can score better on your assessments. Importantly, you can overcome limitations that may be contributed by poor instructors. So while we have variety or variation in teaching styles, one's learning style may not necessarily be complementary to a particular teaching style, and therefore adaptations of one's learning style or knowledge of one's learning style, and therefore maximizing its use, can get around the limitations that you would experience with poor instructors. And very importantly, a reduction in the stresses and frustrations associated with the learning experiences, so that learning becomes fun, you enjoy the program, and it's not seen as being overly stressful. The second benefit are personal benefits. And of course, once you have understood and can maximize your learning style, it does lead to an increase in your self-confidence and your improvement of your self-image. You develop insights into your particular strengths, weaknesses, and habits, and those inform your learning strategies. And of course, it allows you to maximize the advantages gained through utilization of your natural skills and inclinations. And the third benefit, the professional benefit, is that you stay up to date professionally. And later on, we're going to touch on lifelong learning, which is one of the requirements of the 21st century professional. It does give you an edge over your competitors who may not be as au fait, as knowledgeable about their learning skills as you are. You also develop the ability to manage teams much more effectively. This too is extremely important in the practice of the health professionals in this day and age. Not only improving your team skills, but your cooperation among your colleagues as well. And all of this ultimately transfers from maximizing your learning power to maximizing your earning power. The question I want to pose to all of you is, what is your learning style? Do you know your learning style? your learning style would be what you currently utilize for taking in information. It's also a reflection of your level of interaction with others, your approach towards learning different tasks, as well as your coping strategies for the study environment. Had we been doing this particular session a year ago, the study environment would be very different to what it is today. And none of us can really predict what that study environment would look like in another 12 months. So the impact of study environment on learning style has now become particularly important, highly significant. So, first, assessment. Rate yourself 1, if it's not very well. There are three questions. So rate yourself 1, if you're not very well. 2, if you have a good idea about the topic. And 3, if you know the particular question, the answer to the particular question very well. So the first question, do you know your preferred learning style? Do you know what strategies relate to your preferred learning style? And by strategies, I'm speaking to learning strategies. And thirdly, has your learning style changed over time? So 1, if your answer to the particular question is not very well. 2, if you've got a good idea. And 3, if you know the particular answer very well. To determine whether to confirm your answer to the above questions, or for those of you who were unsure, here are some clues to discovering your learning style. If you can jot down the tasks or activities that you find that you learn very quickly, very easily. And secondly, those tasks or activities that take you a while to complete successfully. You look at yourself and you determine what are the kind of things that you are good at, and what are those things that you don't do so well at. Fifthly, what are your hobbies? Hobbies tend to be things that we not only generally are good at, but things that we are committed to, that we enjoy. And sixth, what are the common characteristics of your favorite teachers? Remember, in an earlier slide, I alluded to challenges with some instructors. So what are the common characteristics of those teachers whose classes you particularly enjoyed in the past? And having jotted down the answers to these, you would now be at the point where you're beginning to get a better idea of just what your learning preferences are. There are several ways of viewing and classifying learning styles. You know, people differ in how they learn, the methods and strategies that they employ, as well as what they're comfortable with. And we believe that this explains why you would find some courses or subjects easier than others. So when the media normally interviews students after the SEA examinations, the frequent comment is that they found the mathematics easy or the English easy, etc. There are some courses that you find easier than others. And of course, it also explains why you learn better from a particular teacher or a lecturer with a particular teaching style, because that marries with how you learn. So teaching and learning are inseparable. And at the University of the West Indies, there has been an investment of significant resources into developing the teaching component so that that alignment, that appreciation for the variation in learning styles and alignment of teaching styles so that the information is conveyed to as many persons of different learning styles as possible. The hope is that that is attained. Now, classification of learning styles, we can start with the very basic. So the concept is that the brain prefers to access new ideas through our senses. And the ones that predominantly affect this process are the auditory, the visual, and the kinesthetic. Auditory learners generally are those who are talkative in class. They can't keep quiet for too long at all. Those are the ones who often get sent to the principal's office or the dean of discipline. These persons tend to learn more effectively through lectures, oral presentations, and unless they hear the material, the information seems to have little relevance to them. The slide also lists some of the other aspects of this form of learning. So persons prefer giving oral reports rather than written ones. They often remember who said what in the past, and that linkage between the speaker and content is one of the keys that they use for learning. They enjoy discussions and debate, and they memorize things well. On the downside, they don't readily understand graphs, schematics, diagrams, models, etc. And they do benefit a lot from working in study groups, in small groups. So the suggestions for those who are auditory learners, read aloud to themselves. They find that they're able to recall much more easily. Describe aloud those things that are to be remembered. Read facts with eyes closed. It helps with the focusing. Use word association. So the mnemonics, this is the group that finds these things particularly useful. We spoke to group sessions, record lectures, and listen to them again. And in this particular period where we have a lot of online content, this is right up the alley for this category of learners. important for the auditory learners is the avoidance of auditory distractions. Takes away from, detracts from their learning, and they can lose important information. The second category are those whose brain tends to be visual. So they learn through visually appealing materials. And again, in the online environment, you will find that a lot of the material are presented visually. There are lots of slides, there are lots of videos, etc. These persons tend to have photographic memories, and a word on photographic memories, while it is a good way of recalling information, in the health sciences, a lot of the assessment depends on you responding in a particular context. So in terms of a disease scenario, you are not going to give all the information you know about a particular disease in answer to a case-based question, but you have to extract the information that is relevant. And persons with photographic memories can be challenged. They can give you a whole page of notes, whereas perhaps only 1 or 2 sentences of the page is relevant to the particular question. Visual learners benefit by having a quiet place to study. They do have concentration problems, so they find it a bit challenging when the lectures go on too long. They often need to see the instructor's facial expressions and body language. It aids them in interpreting the information. And a clear line of sight to blackboards, visual aids, etc., also facilitates this type of learning. And so as a visual learner, it's important that you use multimedia wherever possible. Important also that you visualize information as a picture. It tends to help. And one way of transforming your photographic memory into relevant responses is taking notes or using handouts and looking carefully at the headings, the way the information is laid out, the pattern of the topics, and understanding the sequential nature in which the information is being conveyed. The third category, based on how the brain is responsive, is the kinesthetic learners. And these primarily master skills through imitation and practice. They do benefit from hands-on teaching. They speak quickly and often use their hands and bodies to communicate. And from this, you can appreciate that that's probably 80% of us. In the Caribbean, we do communicate with our entire bodies, not just our words. And for kinesthetic learners, one of the most important things is to study in a comfortable position. So for some of them, sitting still in a chair is not always particularly comfortable. Practicing a technique, demonstrating a principle, etc., engaging in hands-on activities, they find very useful to assist them in learning. One's preferred there is another step, so I gave you a 3-step approach. There's another 5-step approach to learning styles. And the first is considering sensory modes for to process information. And that's what we've just been through, where we look at the way the brain assimilates information. But beyond that, your preferred learning tasks. So some persons like to be given detailed step-by-step instructions, and others conceptualize the task and go ahead on the basis of that. So we often have the situation where you buy a new piece of equipment and you set out to use it, and it's only when it begins to give you trouble that you go to the manual. So a lot of us, we conceptualize, we are conceptual learners, we see the object, we have a sense of how it should be used, and we go ahead and use it. There are others who are practical, who go to the manual first, look at the manual, and then on the basis of that, they perform the task. Now, it is not a clear-cut case where one is either a practical learner or a conceptual learner. There is a scale, and each of us would be somewhere along that scale. Spatial learners are persons who, I guess the easiest way to explain it is that these are persons who are very good at puzzles. So these are persons who who are the backbone really of the entrepreneurial class, the innovative class. So where we see a whole muddled landscape, they can see how order could be placed on that. And this is the way they visualize the world, and they can rationalize it and learn it very, very simply and logically. Verbal learners, on the other hand, rely on language skills to achieve the same thing. The best examples advised of verbal learners are politicians. So they present you with a particular scenario. It makes sense to them, it may not make sense to you at the time, but ultimately they get to their destination, they get what they want out of it. The fourth is your preferred level of social interaction. And we have some who have good interpersonal skills and prefer working with others, small groups, their peers, they interact well with lecturers. And there are others who have strong intrapersonal skills. So they know themselves, they know their strengths, they know their weaknesses, and they prefer working alone, and they are self-directed learners. And the fifth of the group would be, or the fifth category is your preferred approach toward learning tasks. And this is similar to the third heading that I spoke to above. Rather than abstract operational knowledge, here these are persons who learn through discovery and experimentation, or others who are pragmatic, want to lay things out logically, systematically. These are the persons who would be following the rules. The creative learners would be the ones who would see the end. In some instances, see the rules as being barriers to getting to the end and take the shortcuts. Again, in these, there is no one or the other. It's a spectrum, and all of us will be somewhere along that spectrum. So to summarize, these would be the learning styles. Each of us would be an amalgamation of some of these, more than one of these. Some of them we are better, others we aren't as good, but each of these preferences, these learning style preferences, has specific strategies that work best. So there is no one size fits all in terms of one's approach to learning. The last thing I wanted to speak to is the concept of multiple intelligences. The question I'm posing is this: is someone who can understand another's emotion and counsel them, is that person as intelligent as someone who can create software? And to explain that, the theory of multiple intelligences was introduced by Howard Gardner. And basically, it's what we have just spoken of, but developed in a modality that speaks to more to the application. So again, it's the same content, the same concepts that we've been looking at, but placed in a slightly different language. What Gardner has added that we have not looked at is the naturalistic, and this is the area that has to do with nature, nurturing, relating information to one's natural surroundings. And this is going to be significant for you because now we are speaking to health teams working in a One Health setting where both human, animal, and the health of the environment are seen as interconnected, inseparable, and impacting on each other. Lastly, I just want to look at barriers to learning, and particularly in these times, where one is working remotely, so the family and social commitments are not divorced from learning. You are not on campus separated from that. You are in the household most of the time, and therefore there is a competition for your time, and in some instances, a competition for resources. Child care for those of you who have families, the internet and electronic devices. There are some challenges. Internet may be poor, and sometimes the electronic devices in your possession may not be up to mark and provide you with the kind of digital environment that you're seeking. And synchronous versus asynchronous learning has now become a significant barrier to learning for some. Synchronous learning is where we are all together and we are sharing in the same teaching and learning experience at the same time. With asynchronous learning, we may be learning the same thing, but at different times. So that, for example, in the online environment, a lecture can be posted and students can access that lecture at their own convenience. So it's not in an interactive classroom setting. It's spatially separated. And for some persons, this is a challenge that they need to deal with. So I've spoken to COVID indirectly while in alluding to the current challenges that we face. Another point that I want to make, and this is common to all your programs, is that the programs in the Faculty of Medical Sciences are either already accredited or in the process of seeking accreditation. And this is professional accreditation that is offered by the Caribbean Accreditation Authority for Education in Medicine and other health professions. It's abbreviated to CAM-HP, C-A-M-HP. And CAM-HP does set some standards that students must meet for graduation. Among the requirements are that students must be exposed to and capable of self-directed learning. And you're going to find that this is a core learning strategy in the faculty, and it's something that you need to adjust your learning style to treat with. You're going to be given more information on this when you do the PBL workshops. There's also a requirement that all healthcare professionals practice lifelong learning. So at graduation, that is not the end of your learning experience. You are required to be lifelong learners. All, again, to be capable of functioning as part of a team, have excellent communication skills. And this communication skills is not between yourself and your patient or client only, but your peers, the other members of the healthcare team, and your community. Diversity, understanding the role of your profession in gender issues, cultural issues, the context of the variety of belief systems and how they impact on persons' approaches to and utilization of the healthcare systems are also a requirement, and I've already spoken to One Health. So to incorporate all of these requires that you must utilize a variety of learning styles. One will not be enough. So to end, answer true or false. 3 questions. Most people only have one preferred method of learning. 2, there's no need to work on improving your areas of weak learning styles. 3, my learning style will most likely not change over time. I thank you for your attention, and I wish you all success in the years ahead of you. And welcome again to the Faculty of Medical Sciences. Thank you.
Thank you very much, Dr. Simmons, for that presentation. Moving right along now, we have our last presenter for the day is Professor Donald Simeon. Professor Donald Simeon is the Director of the Caribbean Center for Health Systems Research and Development. He's also a Professor of Biostatistics and Research at the Faculty of Medical Sciences. He is a Chartered Statistician and Fellow with the Royal Statistical Society. He is a Senior Research Scientist with over 75 scientific publications in peer-reviewed international journals. Professor Simeon, I hand over to you now. Thank you.
Good morning and thank you, Diana. I will share my screen now. and you will let me know if you are seeing it, please.
Yes, we are.
Okay, excellent. Great. So good morning to everyone and welcome to the new students. Welcome to the UWI. Welcome to the Faculty of Medical Sciences. And of course, welcome to this week of virtual orientation. I'm going to talk about research. You know, I noted that your previous sessions included professionalism, learning styles, etc. And of course, the faculty sees research as a big priority, and hence I was asked to share with you some of my thoughts in the area of research and it being a key to optimal public health. I'll be talking a bit about public health because I'm not sure if you are aware of what public health really is. Of course, you'll get more lectures on public health later on. I'll go into public health research. I'll then talk a bit about the research center at the Faculty of Medical Sciences, that is the Caribbean Center for Health Systems Research and Development. And importantly, I'll be talking about undergraduate student research at the faculty and of course, how you what is expected of you, and of course opportunities for you to go beyond just what you have to do, but identify, you know, what else can be done. Public health can be defined, well, first, what is health? Defining health, health can be defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This is a definition from the World Health Organization. Public health, on the other hand, can be defined as the science of protecting and improving the health of people and their communities. This is achieved by promoting healthy lifestyles, researching disease and injury prevention, and detecting, preventing, and responding to infectious diseases. This definition came from the Centers for Disease Control and Prevention of the USA, CDC. There are different approaches. Well, the approach to public health can be seen in four main pillars. And the first step is to define what is the public health problem. That is usually done by identifying what problems arise through various surveillance activities. Countries have surveillance systems which are used to identify, you know, what are the problems at hand. And the next step is to identify, you know, what are the risk factors, and of course, is to determine what is the cause of the problem. The third pillar can be described of, so now that we know what is the problem and what is the cause, the next step is to actually do something about it. What works to really address this problem? Of course, what interventions can be used, and of course, how well do the interventions work? The fourth pillar is how do you then implement it? So you know what is supposed to work, and of course, implementing it can be a big challenge. I mean, we are in the middle of a pandemic and we know what may work to really achieve some level of control, to manage the number of new cases, but of course, how do you implement it? An example, Trinidad and Tobago, of course, is the wearing of masks. How do you get people to wear masks is one question that we have to address. And of course, that can and should be addressed by, 1 minute, take off my phone. Yes, yes, so, and this can be addressed, of course, by identifying, you know, why do people not wear masks? And of course, it is really based on the conduct of research. So it's about going from the problem to identifying what is an appropriate response that we can actually go forward. I was told that I am not, you are screen sharing. I guess folks can see my screen. Yes, okay, good. Yes, moving on now. So we have spoken about the main components of public health. Now we'll talk a bit about public health research. And again, starting with some definitions. What is research? Research can be defined as a systematic investigation that contributes to the production of generalizable knowledge. Health research, on the other hand, is defined as the production of knowledge with the aim of understanding health challenges and mounting an improved response to them. Public health research aims to shed light on the influence of the factors that determine population health, talking about genetic factors, environmental factors, social factors, etc. So the objective of public health research is to use research evidence to propose interventions, innovations, and policies based on scientific evidence to help improve health and well-being and to reduce health inequalities. And the Pan American Health Organization has identified 11 public health functions, essential public health functions. I'll quickly go through them. One is to monitor, evaluate, and analyze the health status of a population, to conduct surveillance, research, and control of the risks and threats to public health, health promotion, social participation in health, the development of policies and institutional capacity for public health planning and management, strengthening of public health regulation and enforcement capacity, evaluation and promotion of equitable access to necessary health services, human resources development and training in public health, quality assurance in personal and population-based health services, research in public health, which we are going to focus on, and the 11th is reduction of the impact of emergencies and disasters in health. Of course, the pandemic is an example of the last. But focusing on the 10th essential public health function, research in public health, this function includes rigorous research aimed at increasing knowledge to support decision-making at the various levels, the implementation of innovative solutions in public health whose impact can be measured and assessed, and intra- and intersectoral partnerships with research centers and academic institutions to conduct timely studies that support decision-making at all levels of the health system. So universities, UWI, Faculty of Medical Sciences, have a critical role in actually contributing to the conduct of research to really address the public health challenges that we face. And as I mentioned, one example is the current pandemic. But of course, my colleagues in the area of chronic diseases, they argue that there's also a pandemic of NCDs, non-communicable diseases, which is perhaps as big as the current COVID-19 pandemic, but that's something that, we can discuss and debate at another time. But just to note that research in public health, brings new insights and innovative solutions to health problems. It also brings the identification and monitoring of innovative solutions and cutting-edge research to advance public health, linkages between public health practice and academic research settings, and epidemiological studies, health policy and analyses, and public health systems research. So these are critical areas. And the last point about public health research is important for us, and that actually led to the establishment of the Caribbean Center for Health Systems Research and Development, which is based at the Faculty of Medical Sciences. We actually physically located in St. Augustine on Warner Street. It's a new center launched 2 years ago with a critical role to facilitate the uptake of research evidence into public policy, programs, and practice. So that is a critical role that we have. And we perform that role by identifying 4 core functions and services. One is to actually conduct research. The other is to translate research findings into knowledge that can be used. The third is to engage citizens. And the fourth is in the area of training. I'll go through each of those briefly. The conduct of research includes the conduct of research studies that would lead to the strengthening of health systems. This also includes research to guide policy development, implementation, and evaluation, and the production of policy briefs. Policy briefs are developed to share the findings of research with knowledge users in an appropriate format. This is critical because researchers scientists write a particular way, and of course the policymakers don't always understand the language of scientists. So it's important to translate the findings of research from what the manuscripts that the researchers would have written into the language that is easily used and that can be taken up by the policymakers. You can see photos of Dr. Babulal receiving an award at the Faculty Research Day in 2019 for the research project with significant potential. And we also see 2 interns who came from McMaster University and who are based at the center working in the area of health policy and systems research. Another area is knowledge translation. The production of evidence briefs are critical in which they identify the best evidence to address a problem, and critically, what are the options to really address that problem. They also are used in the conduct of stakeholder dialogues, which is really a discussion among stakeholders on priority issues informed by the policy briefs. And we are also to be involved in the development of clinical guidelines, which facilitate evidence-based practice using up-to-date and Caribbean relevant research. Citizen engagement is also critical for work of researchers in public health. The convening of citizens forums, and these are dialogues held with citizens to identify evidence-based workable solutions to address the health issues. And this can be used to get the inputs of citizens in defining the research agenda and crafting the research questions, as well as they have a critical role in the sharing of research findings at the end of the research process. Training, the center is involved in training for health professionals in the area of data use, knowledge management towards strengthening health systems, as well as in the area of evidence-informed policy development, implementation, and evaluation. We're also about to start degree programs, research degrees in health sciences, as well as we are involved in capacity building of staff at the Faculty of Medical Sciences. In terms of what we have been doing using the COVID-19 as an example, we convened an FMS COVID-19 research group, which is multidisciplinary, in that we have all 5 schools in the Faculty of Medical Sciences being represented, as well as colleagues from the Faculty of Social Sciences, the Faculty of Engineering, and the Sir Arthur Lewis Institute for Social and Economic Studies, SALISES. And we have been meeting since April, and we have been involved in the conduct of priority research, as well as we have been sharing the research findings, that we have conducted. And these, of course, are to address the challenges that the country, the region faces with respect to COVID-19. The center has also been involved in the conduct of these research. 2 projects that we are currently involved in is looking at the readiness of primary healthcare facilities to manage COVID-19. Of course, we are in the middle of a second wave, and the challenges to health facilities is, those challenges are critical to be addressed, and it's important to identify any gaps that need to be filled as soon as possible. We are also involved in the assessment of the health system response to the pandemic. We have been co-hosting symposia since May. The first was looked at the impact of COVID-19 on health systems. The second looked at the impact of COVID on population health in the post-lockdown era. This was really after the first wave, and the lockdown was eased a bit. So we looked at what was the impact then. Of course, we now know that we are in the second wave. And we hosted a symposium just last week, which looked at evidence to inform a multidisciplinary response to the pandemic, in which we actually had the sharing of research findings of the researchers who are members of the FMS COVID-19 research group, as well as other researchers on the St. Augustine campus. I hope that you new students were able to participate in that symposium that was held last Thursday afternoon. Other examples of research guiding public health policy can be found in the non-pharmacological interventions for COVID-19, research into how the disease is spread, what is the role of masks, is there any research, evidence to show if and how mask works. Issue of social distancing is also determined by research. The closure of schools, is something that is also based on the conduct of research. That is what interventions are known to really have an impact in controlling the spread of the disease. What are the impacts of relaxation on the restrictions? Issue of disease modeling. What can we expect in terms of the number of cases in Trinidad and Tobago, for example, when the second wave? And of course, this disease modeling is also a form of supporting the public health response to the COVID pandemic. Examples can also be seen in terms of how research guides public policy to address non-communicable diseases, NCDs. Research has guided, for example, the policies that has banned smoking in indoor spaces. The impact of secondhand smoke, etc., would have led to that. The seal of sugar-sweetened beverages in school. We note research indicating the impact of diet on childhood obesity, and of course, childhood obesity is linked to later chronic diseases. So one has to start from as early as possible. And again, this is an intervention that is actually guided by research findings. Another example is in motor vehicle accidents. Again, research has indicated, the benefits of wearing seat belts in cars and helmets in persons who ride motorcycles. I would like to end by focusing on undergraduate student research. As I said, research is a priority in the faculty, and students, have a part to play in more ways than one. It's part of your curriculum, but also, the research that you conduct, the findings are used to guide policy and practice. And as such, the schools of medicine and dentistry have year 2 group projects that have been very successful. I'm aware that these projects have been conducted for the last 20 years. And importantly, the students have been presenting their research findings internationally. I know that this faculty does support the travel of students to present research findings to conferences for which their papers have been accepted. And I am also aware of a number of prizes that have been won by these student projects at these international conferences. So this is really a best practice, so to speak. But in addition, the schools of veterinary medicine, as well as nursing and pharmacy, also have a research program in which final year students conduct group projects. Again, it's very high standard, and it contributes a lot to building capacity for students to conduct research beyond graduation. And so the benefits include student and faculty research days. Last year, for example, there were a number of student research days as well as overall faculty research days. The students also presented along with the lecturers prizes were also won there. I mentioned before presentation at international conferences, but critically, a number of research papers that have been produced from student research have been published in international peer-reviewed journals. So that is really something to look forward about. But of course, beyond the research that you have to do as part of your program, those research projects, I myself would like to see students being involved in research even more. It's about identifying other ways to get involved in research. And if you really would like to become involved, it's important to express your interest to researchers, perhaps those you have worked with, perhaps your supervisors for your research projects, or those whose work you have seen presented at different fora, whether it's internally or externally. We have a number of internationally recognized researchers in the Faculty of Medical Sciences, and of course, it would be good to work with them, to learn from them, and to really gain from their experiences and expertise. You can get involved by assisting in data collection, conducting literature reviews, being involved in planning meetings, presenting findings. Of course, it's about working with a team, and of course, identifying researchers, who share your interests in what research is being conducted. It's also useful to align with researchers or research in the field that you plan to specialize in. I mean, you would have your specialization plans, and of course, there are persons doing research in those areas. And if you have a track record of doing research in those areas, it really does improve your chances of being accepted into various residency programs, locally as well as internationally, especially internationally. I mean, having publications or research experience makes a big difference, because as you would know, it's very competitive to get into residency programs. Some may say easier said than done, and at time could be a challenge because your schedule is so hectic, it's so full. But the reality is that, there are a number of successful examples where students have become involved in research, supporting researchers, faculty members, and of course, being involved in the publication of journal articles, and of course, being in a better position to compete for places in residency program, but also to contribute to knowledge that is generalizable, and critically knowledge that can be used to strengthen the health system, to guide policy in Trinidad and Tobago and in the Caribbean as a whole. I think I would end at this point. And of course, I think that there is a facility for questions to be asked. So I hand back over to Rihanna.
Thank you, Professor Simeon, for that. You hearing me?
Yes, I'm hearing you, yes.
Great. Thank you very much for that presentation on your research. And this concludes today's orientation session for all of our new students. The rest of the week, we have our program is available, our schedule is available on the FMS website. You would have also received an email with the schedule. I thank all of you all for being here today and participating in our first year orientation experience. Until tomorrow. If there are any questions, you can feel free to comment your questions in the chat or send an email to us. Thank you.